Hello and welcome to the Pulse of Manatee, brought to you exclusively on METV. I'm your host, Dr. Srini Iyengar. On today's show, I want to address the topic of wound care. We've all had cuts and scrapes that we can take care of at home. But what about more serious wounds, the kind that may be the result of an underlying disease and involve a potential hospital stay? Some non-healing wounds are associated with complications from diabetes or other vascular-related disorders such as inadequate blood circulation and poorly functioning veins. Up to 15% of the estimated 17 million Americans with diabetes may suffer from chronic wounds, most commonly non-healing foot sores, which potentially can lead to amputation. Today, we have a team of experts to discuss the causes of these chronic wounds and offer tips for prevention. Let me introduce our panel today. To my extreme left, we have Mario Garudo, an LPN and hyperbaric oxygen therapy director at Manatee Memorial Hospital. Also, to his right, Dr. Aaron Cooks, an infectious disease specialist who's also the medical director of the Wound Care Center at MMH. Guys, thanks for being here. Let's get started here. This is a big problem, and I think a lot of our audience watching right now really underestimate the severity of people having ulcers or nicks or knacks to their feet. Aaron, I want to start with you here. What is the importance of someone saying, hey, I got a cut on my foot. It's been about a week. I put Neosporin on it. I put a Band-Aid. It's not getting better. Why should I care?
Well, wounds can be chronic and non-healing for a variety of reasons, like you mentioned. If they're not healing well, usually there's an underlying reason, and we as a team get to the bottom of that reason and help the wounds heal much faster. On average, we can heal most wounds in about 7 weeks, and we get people who present to us who've had wounds for 3 to 9 months sometimes.
Well, let's, Aaron, I think before we jump into the Wound Care Center, I want to know a little bit more about the people at home thinking about what the ulcerations are. So let's just talk about what actually causes it. Now, Mario, give us a little more commentary in the background here. Do you see patients when you see in the Wound Care Center? Are they diabetics, smokers, both?
Yeah, I think we see both. I think the issue may be, the person is sitting at home thinking, I've had this same thing before. It doesn't look any different, the Neosporin is just going to take a while to work, or, I'll keep walking and I'll walk it off, or it's scabbing over, yeah, it's getting a little red, it's not a big deal. So they may think, I've had this in the past, it's just taking longer, I'm getting older, it's going to take longer to heal.
And that's the thing everyone at home to remember. It's not an issue of just age as much as it is understanding that an ulcer on the leg may be just that, a superficial ulcer, but it can also lead to something more serious called osteomyelitis. Aaron, you want to describe what osteomyelitis is to the home?
Osteomyelitis, by textbook definition, is inflammation of the bone, and we usually associate that with infection. So when a wound gets so severe, it can directly extend down to the bone and lead to more morbidity.
Now, let's go backwards then. So everyone watching right now, I want to really emphasize that these should not be taken for granted. That's what we're trying to emphasize
Absolutely
right now.
Not.
So a patient, hypothetically, Mrs. Jones, 70 years old, at home, diabetic, has a ulcer on her ankle. It's been there for, she doesn't know, maybe her cat scratched her, maybe she scratched something on her desk when she was walking. Been there for about 2 to 3 weeks. When is it time for Mrs. Jones to call you guys up and say, listen, I think I may need to get evaluated? Or when is a primary care doctor or podiatrist, when should they give you guys a call?
If she's diabetic and she has a wound on her foot, immediately.
Immediately. So that's a take-home message, guys. I think it's very important to emphasize that. Now, Mario, what is the length of time sometimes before the referrals come in to see you guys?
Well, I think like Dr. Cook said, it's anywhere from, it can be from 1 week to 9 months. One of the things about diabetics and osteomyelitis is that if a diabetic wound progresses over 30 days, there's a 70% chance that there's osteomyelitis.
That's huge. That's huge. I mean, 7 out of 10 basically will progress to osteomyelitis.
In just a month. In just a month, this is progressing.
Now, if this patient is seen in time, can we avoid amputation?
Absolutely. Absolutely. We have multiple methods that we can undertake to make sure that that wound heals properly and prevent that extra disease and illness in that person.
Would it start with the primary care or the podiatrist, both? What do you guys think it should start from with this recognition of an ulcer that's not healing?
I think whoever's taking care of the wound at the time, whoever the wound is presented to, the physician thinks, okay, you know, this is a wound, this is diabetic, let's get it over to the wound care center. I think it's the responsibility of whoever sees it first.
Well, again, guys, before we get to the wound care center, I want to know if they see a patient, if a patient's being seen, smoking, diabetes, now how important do they play into the role of an ulceration that's not healing?
Oh, huge. It is critical that we address excellent glucose control, advise people to stop smoking. None of those things help wounds.
Got it. And the thing is that now arterial versus venous. We talked about a little bit about this before the show because everyone at home is saying, well, I have an ulcer. Does that mean I have a blocked artery or does that mean I have a blocked vein or both? Aaron, why don't you comment a little bit between arteries and veins? Like, what are the differences that people should look at for ulcerations from that standpoint?
Well, just basically, the arteries are taking blood down to the foot, replenishing the oxygen and blood supply to the tissues, and the veins are helping to bring the blood back up to the heart. So it is sometimes very difficult to tell which is which, so that's why you need a team approach and a systematic way of learning how or coming up with the diagnosis of which is which.
And I agree completely. Now, this is important because, you know, we work together as a team. As someone of myself, you know, telling that I basically, as an interventional cardiologist, I perform the plumber's role, if you will, of opening vessels up. But I think you cannot just open an artery or a vessel up expecting to heal. You need the wound care center's help, antibiotics, hyperbaric, wound care locally, everything to be done together to get these things to heal. So now let's move into, Mary, a little bit of your expertise. What is hyperbaric? Because let me tell you something, when I first saw this years ago, I thought hyperbaric meant, are we having a diving team in Manatee? Like, why are we having hyperbaric therapy in Manatee Hospital? Because historically, to be people at home think this way, same way, hyperbaric chambers were used for the bends when people were rising too fast after scubaing too far. So why is hyperbaric useful in wound care?
Well, to start off, you know, hyperbarics is used for the bends, you know, still, but I think directly related to wound care, let's take, for instance, this diabetic foot ulcer that, you know, has been progressed for over 30 days with osteomyelitis. The hyperbarics is an adjunctive therapy. It's used with infectious disease. You know, we bring that in. We want to make sure that there's good blood supply. But what it does basically is it's pressurized oxygen. It's in a chamber, open.
Let's talk about that. The chamber. How big of a chamber is it? Because I want people at home to realize that is it around their body? Is it around an extremity? What kind of, how big is this?
Yeah, it's fully submersive. It's a open chamber. I think the dimensions on it are like 42 inches.
Claustrophobia?
Across.
Do people get claustrophobic in this at all?
They may. A lot of the time, people with claustrophobia, if they're claustrophobic, it means like when they get in an elevator, closed environment, they're claustrophobic. This is an open, it's got a television on top of the chamber.
Great. Well, this is important because like an MRI, we tell everybody, oh, MRI, and then they get in and they scream because they want to get out of it.
No, this is completely open. You can see your complete surroundings. There's a television. You can hear the television. You can watch movies, listen to CDs. You know, it's very interactive for the patient as far as what they want.
Definitely. Patient-friendly in that
sense. They're able to
sense.
Communicate with a technician at all times.
So Mrs. Jones has this ulceration. We've talked about the diabetes and smoking. She's now seen you for the wound care center and the hyperbaric therapy. How long, how many times, what is the background of what's the therapy like?
Right. So basically it goes upon diagnosis and what the physician deems necessary. But what we see typically, like what you're saying with the diabetic foot ulcer, would be 30 treatments. So that's 5 days a week. It is 2 hours a day. So it's a big commitment, but it provides great progress. You know, in conjunction with IV antibiotics and some other things, it has great healing rates. We do treat till healed. So that's our biggest thing, is that we know it works because we treat.
Definitely, and I feel like it's an awesome part of the armamentarium is to have a hyperbaric chamber, but this is unfortunately a question we've got to ask because I want everyone at home to understand this too, is to pay for it? Is insurance cover this type of therapy?
Right, and I work with that specifically myself.
Got it. So
I
tell us a little bit about that. How
Okay.
was the negotiation with insurances about the therapy length of time? You know, they pay for
Right.
one session and not the all. How does that work normally?
Specifically with, let's go into Medicare and a secondary.
Yeah.
Medicare and a secondary would cover the entire treatment. You know, we're basing this on that the patient is, you know, appropriate for hyperbarics.
Okay.
It would be 100% covered. Medicare, just like anything else, covers just 80%, so that extra 20% is either covered by the patient or by secondary
Got it.
insurance. Most private insurances, you know, it's based on physician dictation. What is the physician saying about this patient that's letting us get
Well,
that private
and that's
insurance?
key. What is appropriate criteria, like you just mentioned? What would be, Aaron, what would be considered appropriate for hyperbaric therapy?
The indications?
Yes.
Diabetic foot ulcers at a certain grade, they're staged at things called a Wagner grade 1 through 4. So 3 or 4 definitely get in. We also do soft tissue radionecrosis, osteoradionecrosis for people who've had radiation therapy and they have long-term damage. There are other soft tissue radiation injuries that may go in. Say if you've had prostate cancer and you're having trouble with urinating or pain, or you're seeing blood in your urine, this is a great tool to help. There are some other indications such as the bends, severe anemia that we don't really use because those are in the more acute
But there
setting.
are other modalities that can be used, or other therapies, other disease processes that can be treated with this.
Absolutely. There's a list of 15 and they're all Medicare approved.
Well, great, because that's important, because in our population here, especially in Florida, I think the big thing is that people are living on limited budgets.
Absolutely.
And we have to be cognizant of the fact that the therapy has to obviously justify the means to get there. And I think that this is a great, because not many centers have a hyperbaric center for wound care. Because the thing is that it adds to what we can do for a patient. But again, on top of that, we have to look at, the ulceration itself. So if it's upper extremity, lower extremity, Mario, no problems, correct? It's the same thing, or is it just lower extremity?
Well, it depends what he's saying with the diagnosis is. Obviously, if it's a diabetic, it needs to be a lower extremity
Got it.
wound. We do some acute arterial embolisms, which can be upper extremity, lower extremity. So we do treat that with hyperbarics. And obviously that's based on
It's covered by the indications.
Right.
Now, Aaron, tell me a little bit about the fact that we have the hyperbaric indication, we have the people that are coming in there. What do you do before the hyperbaric, but after we've sent the patient in? What's the kind of the middle of the road there? What's the other stuff that goes on?
As far as qualifying for hyperbarics?
Or actually for treatment of any ulceration?
Treatment of any ulceration. We have 9 essential steps with the management company that we use, and it's all rooted in evidence-based medicine, so it's all in standard of care procedures. We want to assess their blood flow. We want to see if they have a diabetic foot. We palpate a pulse. Not only do we try to palpate a pulse, we also do what's called an ankle brachial index.
Which is very important for everyone at home. And an ABI, or ankle brachial index, which Dr. Cook just mentioned, is essentially a blood pressure cuff on the arm and the leg, and just physiologically checking the amount of flow that is running between the upper body and lower body,
Right.
which is really important because it really gives us a good estimation of how much flow is getting to the foot.
And if it is too low, that's when I call up my friends like yourself, and we see if there's a problem with the blood flow.
And I think it's important to emphasize too that it's never a one-person job. I mean, it's never like one person can come in there and heal this ulceration. I always tell every patient that comes to see me, it's really a 3-prong, if not 4-prong approach. Number 1, you get the flow to the leg. Number 2, you get the antibiotic care through your veins or orally. Number 3, you get the local wound care, which includes the hyperbaric approach, which could be the 4th part of this process. But I think a lot of times it gets missed is when I talk to these patients, they don't have that primary care doctor that's actually managing the sugar. Or they're like, smoking? Oh, I know it's bad, but I didn't think it was this bad. How do you talk to the patients about the smoking?
Well, I tell them that it is critical that they stop smoking because we know that nicotine constricts the blood vessels. And if we're constricting blood vessels, we're restricting the blood flow, and that's never helpful to healing a wound.
I think
in the long
that
run.
point alone is important. Restricting blood flow by constricting vessels. I think people think smoking is bad for me because of cancer, but they don't realize that it actually constricts blood vessels. You're getting less flow to your leg for it. Mario, have you had any success talking to patients about smoking? Or what is your
I don't have any secret, phrase that I give to a patient, but obviously just continuing and just adding to what the physicians are saying. The nurses need to be right there. This is calcifying some of your veins and arteries. This is not letting us get an accurate reading of the ankle brachial index, which is why, some of the reasons why we have to go to someone like yourself.
That's the thing is, I think patients, I hate to use scare tactics, but I'm always curious, do you guys ever use this is what an ulcer looks like when it doesn't heal, and this is what it does when it does? Do you guys ever show the before and afters and let them know, or at least show them other examples? Because I really feel that, I hate to say it, but sometimes the patient needs to see that this is what happens if it doesn't get treated appropriately, if you don't stop smoking, if you don't get the proper care. Do you guys ever show them before and afters as well?
Well, I think specifically with the patient themselves, they'll come in and say, this is what the wound started off with. It wasn't that bad when it started. That's the before and after. Look, this is where you were in 4 short weeks, here you are now with this, big ulceration. Obviously something is happening here, and the Neosporin and the Band-Aid isn't working.
And that's the thing. I think a lot of people at home have to understand that it's just not about Neosporin and Band-Aids. I mean, if you have these other conditions, other than diabetes and smoking, though, Aaron, is there anything else that you would notice that causes these wounds not to heal? Is it being on steroids or anything else that you've noticed?
Oh, absolutely. Steroids is a great one, because we have people who have other conditions that require steroids, and so we have to also call up the rheumatologist and kind of talk with them and say, hey, maybe we can cut back on the steroids or some of their other immune suppressant drugs so that we can actually gain some ground here.
Excellent point, because yesterday I saw a patient in the office from the wound care center who basically is on chronic steroids for arthritic pains, and I said, listen, this is hurting your foot. I understand the shoulders are not feeling too well, but you've got to understand steroids are a big problem when it comes to wound care itself. Now, you mentioned that talking to the rheumatologist, you also have to talk to the pulmonologist.
We talk to pulmonologists, we talk to cardiologists.
You can't blame us. We don't play people on steroids. No.
Well, it's a collaborative effort, like you were saying before. It's a team approach, and that's one of the important things that we try to emphasize at our center, is that we pick up the phone, we speak to the primary care physicians, we help get referrals to the other people that we may need help from.
Now, the thing is, we've talked about the hyperbaric, we've talked about identifying the ulcerations. Let's talk about your original specialty, infectious disease. Talk a little bit about that, Aaron. Like, when it comes to antibiotics, how is that basically introduced to the patient? Is it always intravenous, oral, or is it a mix?
I think, well, it's a mix, and there are other methods of giving that medication as well, because often an ulcer on your foot or your arm, that's local. That's not systemic. And I myself don't really want to give systemic antibiotics unless I have to. So we have other wound applications like wound care gels that have antibiotics in them that will help right there locally without me affecting the rest of their body.
That's great. Now, do you also use oral antibiotics with that, or just the gel?
Sometimes just the gel, if it's just there and it's not a huge problem. And we see our people weekly so that we get to see them on a weekly basis to make sure that things are going right. And if it's not going right, then we can add orals or IVs or
And is this
methods.
over-the-counter gels, or are they something that you
No, it's usually prescription.
So it is important to notice, because I don't want people to say, well, I'm just going to take that Neosporin now. It's antibiotic. I can just put it on and see how that works. Now, let's compare that gel that you're using compared to Neosporin. Much more potent or focused, would you say?
Much more potent and focused, and I'm not a big fan of triple antibiotic cream, because often people will come back and tell me, oh, I got this rash, and now which part of that medication gave them the rash?
Exactly, you're right, because we know a lot of rashes are medication induced here. So Mario, typical comment about length of time. You said, what is the average? What do you think is the average time for an ulcer, diabetic foot ulcer, to heal? What do you think?
I mean, our standard at our center would be like 12 to 14 weeks.
And follow-up after that, what's the follow-up usually? Did they follow up with their podiatrist, their primary care? Did they ever come back for?
Oh yeah, they're continuing following up with whoever they see to start with. They can come back and see us at any time. They don't necessarily have to have a wound. If they have an area that they're worried about that was in the same area or in a different area and they just want to get it checked out, we can do a one-day consult. They can come in, we can take a look. It's quick, easy. They're not, if they just have a question. I think that's a big hit for
definitely
people at home.
And now for debridement. Now, debridement for everyone at home means actually, would you say, just cutting onto the ulceration around it, taking some of the scar tissue or scab tissue?
That's part of our 9 essential steps, and that's what we call removing non-viable tissue.
Good. Well, that's important. And let's explain it to everyone at home. Non-viable means basically dead tissue, correct?
Dead tissue.
Dead tissue. Removing dead tissue from the area of the ulceration. Now, in the wound care center, that's being performed primarily podiatry and all the physicians are doing it?
All of the physicians who are there.
Excellent.
Because we want to remove that bioburden, that biofilm, that dead tissue, so that we're stimulating growth.
Excellent. Now, would that be done on a weekly basis as well, or
if needed? And most often it is, because even by that mechanical action of removing that tissue, that helps to stimulate the growth factors to walk across that wound and heal.
So basically, it's scar tissue. We're trying to get some growth, new growth of tissue by cutting into the tissue or the good tissue.
Yes.
We want new tissue to form over that, basically.
Yes.
Well, that makes sense, a lot of sense. Now, when that's done, though, does that make the process a little longer with the hyperbaric, or does it help the hyperbaric process?
It actually speeds it up, because when we remove that dead tissue, now it has room to breathe, room to grow, and we're removing that tissue, and that mechanical action is stimulating your body to promote hormones and growth factors to help that wound heal.
Excellent. And the thing is, medications with this, other than antibiotics, is there anything else you guys give during this period that needs to be, even vitamins, antioxidants, anything of that sort?
I think the big thing that we haven't really talked about yet is offloading.
Yeah.
We provide offloading to the patient, especially with the wounds in the lower extremities. These patients don't need to be walking on this wound will never heal.
Explain offloading. I want everybody to hear that. What is offloading exactly?
Offloading is a couple things. So, when you're at home, you're off your feet, you have your wound up and, you have your leg up in the air, you're letting that wound breathe, basically. You're letting that, the dressing is still on there, but you're letting that wound not have so much pressure on it. People think, well, I'll just walk from here to the refrigerator. You're putting pressure on that wound. You are creating that wound base is getting stress to it.
What would you suggest then for a patient that says, hey, I live by myself? What could they do? Would crutches help? Would it be even wheelchair bound? What would you suggest?
Well, we provide a lot of different ways to do that. Obviously, if this patient has some insurance, we can set them up with orthotics, or the podiatrist. We'll send them to a podiatrist to see what kind of offloading they think is necessary and adequate for that patient. So again, we're back to the team effort. If we have somebody who we think needs a specific kind of offloading, we're going to outsource to somebody and say, hey, we need some help with this.
Right now, someone's watching, says, you know what, I have an ulcer on my leg, but I'm sitting down with my foot on the ground. Should that person now have that foot elevated?
When at rest, absolutely. I always tell them to keep their legs up, because that is working against gravity. When their legs are down, there's fluid that's building up in their legs, and so getting that leg up, you're fighting against gravity and helping your wound.
Got it. So that's key here, because some people would think the reverse, think, well, you know what, I want my leg down because I want more blood to flow to my leg to heal this area, but we're really trying to say offload it, take some rest off it, and make sure that you're not having enough pressure on it. Now, the bandages around their legs, how often do you guys suggest changing this? Is that weekly? Is it daily?
We look at them at least weekly, and depending on the wound, how much drainage it's producing, we will often get home health care nursing to come into the home and change it as often as we need. Sometimes that's daily, sometimes it's every 2 to 3 days, but we make sure that it's appropriate.
That's critical, home health with involvement. Now, do you guys have to make sure it's a wound care certified home health, or just any home health would do?
Well, most have certified wound care nursing on staff so that we can work with them, and we send out orders. We give a copy of the orders to the patient. We fax a copy to the home health care agency, and we have one on file, so that if there are any questions, they can always call.
Now, the question is, how would the patient who's watching this right now say, I want to go there? Do they need a referral from their physician?
No, they don't. Not all the time.
all
It
the
can be a self-referral. If this patient, like we talked about earlier, if this patient doesn't have a primary care doctor, they're not seeing any doctor right now, but they have an ulceration on their leg, we're not going to turn them away because they don't have a physician
Well,
referral.
that's what's important, because I think everyone at home may say, well, I've been seeing this, I'm not going to just insert any doctor's name or insert person or specialty, and they're not happy with it, and they are interested, they see the wound care, but they're fearful of, do I need a referral? I mean, could they just literally walk in or call you guys up and say, listen, I'd like to come in and get evaluated?
Most often not, but there are some insurance plans that require the patient to have referrals.
Got it. Well, that's important to know that too, because I really think the biggest issue with patient care right now is insurance. A lot of this has to do what covers what and what doesn't cover certain things here. Now, the main thing at this point, guys, before we wrap up, I want you guys to think about your final thoughts here. Why don't you, Mario, start with you. What do you think patients at home, individuals at home watching this show right now, saying, you know what do I want to take away? What's the take-home message for them?
I think the take-home message is pretty simple. This can all be overwhelming. Let us do our job. At the Wound Care Center, we're all about getting everybody together, but we never put the work on the patient. The nurses, the hyperbaric staff, the program director, the physicians, they're all reaching out, doing the work for the patient. The patient doesn't have to do a lot of work except...
So you're not only offloading the wound, you're offloading on the patient.
Oh, sure. We always say we treat the whole person, not the hole in the person.
And that, I think, is such a great point, because if you get focused in the ulcer, you lose the rest of the body. It's like focusing on the tail of the elephant. You know, you miss the rest of the big body. You want the body to be involved, the brain, everything else
Right.
there. So if the patient knows you're helping them mentally, you're not just helping the ulcer, I think it makes a big, big difference. Aaron, how about yourself?
Well, for chronic problem wounds, there is a place for you to come. We can address it. We have a systematic approach. We have great rapport with other physicians in the community, and we're just there to help.
Excellent, Aaron. Excellent, Aaron. Thanks a lot, guys. So thank you again to all my guests for joining us today. Remember, any wound that has not started to heal within 2 weeks or completely healed in 6 weeks may benefit from a specialized wound care center. I would actually even say even earlier sometimes. Ask your regular physician if a referral to a center for wound care might be the right option for you. As always, thank you, METV, for making this program possible. And remember, a positive mind is a positive body. We'll see you next time on the Pulse of Manatee.